So my name is Eric Arzubi. I'm chair of the Department of Psychiatry at the Billings Clinic in Montana. I'm a board-certified child and adolescent psychiatrist and general psychiatrist as well. So we're here to talk to you about IBH Connect, integrating behavioral health into primary care. Part of the reason for my visiting here today also is try to understand what FHIR even is. I have no idea. All I do is I see patients, I'm a shrink, but I'm trying to solve problems at the same time. So we worked with Juxley to try to solve what I think is a pretty significant problem. So Billings Clinic, just a little background, it's a multidisciplinary clinic that's modeled a little bit after the Mayo Clinic or Geisinger. It's, again, multi-specialty, has inpatient and outpatient services, was named the safest hospital in the country by Consumer Reports in 2012. It's part of the Mayo Clinic network of care. And we're proud to have just announced a partnership with the University of Washington to start a psychiatry training program in Montana, actually the first one in Montana. Juxley, a little bit about Juxley. You've heard about them before. They presented yesterday. Focus on user-centered application design, implementations in multiple EHRs, and establishing FHIR development. They're established FHIR development experts. Again, I don't know what FHIR is. So let me tell you about integrated behavioral health, and I'm gonna kind of veer away from the slides for a second and talk to you, not at you for a second. So in Montana has, like many places in the country, has a mental health crisis. Montana has the highest suicide rate in the country, #1. And it's been top 3 for the last 40 years. Lots of reasons for that I won't get into. But I think many of you know, if you work in healthcare, that we have a mental health crisis. We have a huge problem in trying to access mental health care. What are the problems? Well, #1, not enough psychiatrists. Not that we're great people, but we just don't have enough psychiatrists who are trained to take care of folks who are struggling with mental health problems. Mental illness is the #1 cause of medical disability in the United States. Mental illness is the #1 cause of medical disability in the United States. So we don't have a lot of psychiatrists. We know that mental illness is a problem. And I would also pose to you that mental illness has a multiplier effect on both medical outcomes and financial outcomes in healthcare organizations. What do I mean by that? Well, it turns out if you newly diagnose someone with coronary artery disease without any mental health problems, to try to predict outcomes, you look at the physiology of the heart. If you have newly diagnosed coronary artery disease and someone who also has depression, the heart kind of goes out the window, and you have to look at what depression scores look like, what the intensity and severity of depression is to predict outcomes. So if you have someone with comorbid mental health problems and medical problems, your outcomes are going to be worse and you have more expensive care. Now the problem is, again, there aren't enough psychiatrists. So what do? Well, it turns out integrated behavioral health is really what needs to happen and needs to spread more rapidly than it's spreading right now. What is integrated behavioral health? Well, there are lots of different models, but the gold standard is something called collaborative care. The collaborative care model was developed at the University of Washington. It's been around for a couple of decades. And I don't know why it's taken so long for us to get here, where now finally the American Psychiatric Association is really pushing this out pretty aggressively. In fact, this year, CMS finally issued, 2 years ago, they came out with new G codes, so sort of preliminary codes to try and pay for integrated behavioral health services using the collaborative care model, and this year, they're real codes. So what does that mean, and what is integrated behavioral health? Particularly, what is a collaborative care model? Well, here's the situation. It turns out 70% of all antidepressants are prescribed by primary care docs. 70% of all antidepressants are prescribed by primary care docs. So it makes sense that we bring the support to the primary care practices. They're really the first line of treatment for mental health problems. And we need to empower primary care docs and primary care providers. So forget docs, I'm talking providers in general. We need to empower them to be able to treat these conditions more effectively. So what is a collaborative care model? Well, it's team-based care, and it's truly, when done properly, population health in action. So team-based care. Well, you have a primary care doc. Patient comes in. They do a screening tool. It's called the PHQ-9. The PHQ-9 is a widely used depression screening tool that tells you if it's no depression, mild, moderate, moderately severe, and severe. You screen. They go in to see the doc. Now, if the doc has no mental health support, they see severe depression, they get worried. Right? They might start an antidepressant. They might try to make a referral to a psychiatrist, but if there are no psychiatrists, we get a problem. And there are no therapists available, we have another problem. So what collaborative care does is it puts a social worker or behavioral health specialist in the primary care office and allows that behavioral health provider to talk to a psychiatrist on a regular basis for consultation. So what happens? You have a patient panel, you have sort of your little population of patients for the behavioral health manager. You have a population of patients, you're getting PHQ-9 scores, these depression scores that are being taken and then recorded. And now, in the best of all worlds, this behavioral health manager has a dashboard of patients where they can risk stratify, look at who has no depression all the way up to severe depression, and play offense. Try to get ahead of the problem, not waiting until that patient shows up in the emergency room, but actually trying to reach out to these folks and say, hey, you've been screened, you have severe depression, we need to make sure you come in. So the behavioral health manager talks to the primary care doc and talks about their recommendations for treatment plan and doing psychotherapy. And if the primary care doc has questions about what medications to use or what doses to use, the behavioral health provider, that sort of quarterback, will then call the psychiatric consultant, talk for a few minutes, discuss the patient, and the psychiatrist might say, you know what, that Prozac dose is too low. 10 milligrams doesn't make sense, you need to bump it up to 20. So, again, team-based care. But now how do you get everybody to get on the same page? Right, so how does the psychiatric consultant see that list of patients that the behavioral health manager is using, get on the same page, understand how they're stratifying risk, and actually be able to look at the record? Right, because that psychiatric consultant, for example, in the case of Montana, where I'm from, that psychiatrist might be 5 hours away. And I'm trying to provide support to a primary care clinic that's in a town that has maybe 2,000 people. So how do I get everybody on the same page? Well, I use a patient registry. The University of Washington, in the use of the collaborative care model, put a patient registry sort of at the centerpiece of this model, allowing everybody to kind of look at the same information. The problem is, this patient registry initially was an Excel spreadsheet. Then they created their own, but it was a separate product. So when we at the Billings Clinic started to roll out integrated behavioral health using the collaborative care model, we reached out to the University of Washington and said, we'd love to see that registry, can we use it? Like, sure, it's several tens of thousands of dollars, but it lives outside of our EHR, we use Cerner. So, and I asked them, well, has anybody done this, where they actually make this thing talk to the HR? Like, no, nobody's done that yet, but it'd be like the Holy Grail. So we reached out to Juxi. He's like, I don't know anything about this stuff, but we need a patient registry. I can't have my providers, I can't have my behavioral health managers looking at this one registry that I'm going to spend a lot of money on and look at Cerner and try to get on the same page. This doesn't make sense to me. You guys have a solution. So we worked together to come up with IBH Connect. And IBH Connect is this patient registry that actually talks directly to Cerner, at least to start. And what Juxi's telling me, and I trust them so far because they've delivered, is they'll also be able to do it with Epic and other EHRs as well. Because what I'm trying to do in Montana, again, highest suicide rate in the country, is how do I empower primary care clinics to provide better behavioral health services? Because I'm never going to be able to see all those patients. So if I can get all these primary care clinics to use a registry like this, and I can look at their patient population, look how they're stratifying risk, I can help them play offense, get ahead of the problem before they show up in my emergency room, and provide better care. And that's the goal of a patient registry. So, we're talking about integrating behavioral health into primary care, right? It sort of simplifies, shortens the path to psychiatric care in the way I was kind of describing to you. Expands psychiatric capacity. What does that mean? Well, right now, we have enough psychiatrists to do the following. If every person who needed a psychiatrist could go and see a psychiatrist, in a rural setting, I could give you 3 minutes. And then I'd go have to move to the next patient. In an urban setting, it's about 6 minutes. I mean, that's the capacity we have right now. So imagine now, if I'm doing integrated behavioral health, I can review a patient panel, again, a subpopulation of patients, with a primary care provider and this behavioral health specialist in primary care. I can look at a whole panel. So now I'm leveraging my know-how, and rather than seeing one patient at a time, now I can empower this primary care office to see more and more patients and kind of disseminate my expertise a little bit more effectively than just seeing one patient at a time. And that's the point, right? In terms of patient outcomes, well, you're asking, this all sounds awesome. Does this make any sense? Does it work? Well, again, this has been done for 20 years. There are about 80 randomized controlled trials of collaborative care model, and they've shown across populations, across different geographical settings, that this works. And in fact, it works twice as fast in reducing depression scores by 50%. Twice as fast versus treatment as usual. And what is treatment as usual? Treatment as usual is you come in, hi, I'm anxious and I'm depressed. And then people say, well, let me get you, you need to see a psychiatrist, but it'll probably take 6 weeks. That's treatment as usual. So how often do you think they actually follow up? Right? And how often do you think follow-up actually happens and people get engaged in care? 50% of the population will at some point meet criteria for mental health problem. So, again, IBH Connect is our patient registry. And what are we trying to do? We're trying to embed it into existing workflow. Again, getting rid of this outside registry to make sure it's part of our medical record. It displays real-time EHR patient data. It shares, we have a shared view, which simplify these team reviews again, right? We have 3 team members, of course, including the patient if you put that to center, but the patient is not looking at this. This is not a patient-focused application. This is a team-focused application to make our work more efficient and more effective. And the other piece is we talked about the CPT codes, right? Talked about the CPT codes. I'm going to read something to you. So the University of Washington put out this sort of a cheat sheet on the new CPT code. The CPT code is, there's several of them. I'm going to give you the first one, which is 99492, for those of you who are interested in CPT codes. Well, you guys threw all this other jargon at me, so I'm going to throw this at you. So 99492, the first 70 minutes in the first calendar month for behavioral health care manager activities in consultation with a psychiatric consultant and directed by the treating provider, which is the primary care doc, right? What does that include? Well, it includes that person reaching out to patients, the initial assessment, including the administration of validated scales and resulting in a treatment plan, the review by the psychiatric consultant and modifications if recommended, entering patients into a registry and tracking patient follow-up and progress, and participating in weekly caseload reviews with a psychiatric consultant, and the provision of brief interventions using evidence-based treatments such as behavioral activation, problem-solving treatment, and other focused treatment activities. So what I'm saying is that even the idea of a registry is embedded in the definition of the CPT code. So our hope is, that IBH Connect will allow practices to, number one, have a registry that talks to the patient data, and vice versa, number one. Number two, improves patient outcomes by improving the workflow. And then number three, allows practices to bill more easily. Because right now, people don't have a method to kind of collect this. This CPT code is new. So wouldn't it be cool if something like this actually accelerated the uptake of the CPT codes and started making integrated behavioral health more accessible? Now we're doing the live demo. How am I doing on time? 4 minutes. So I have 5 minutes left. Great.
You have the browser?
Browser, can we get the browser on, please?
Actually.
Okay, we got it.
Like you can...
Okay, thanks. So this is a patient registry, right? So this is my population of patients at, let's say this was a Billings clinic. These are not real patients, as I hope you can imagine. So let's say there's a patient population at the Billings clinic. Now, at the Billings clinic, we have several outpatient clinics. Here's what I can do. I can look at all the patients, or I can actually click here and sort by just looking at the ones that I'm caring for. These are the ones that are associated with me. I'm going to go back to viewing all. The other thing I can do is I can look at their status. I can sort this patient population by status. So active treatment. That's actually, I'm monitoring their depression scores. I'm actually getting them to come to the next appointment. They're in active treatment. I'm trying to lower the depression scores. And then there's active and prevention. So the prevention phase basically means once the patient I've gotten them to either remission or a 50% drop in depression scores, now I'm preventing their relapse, right? And then I can also sort by inactive and some other things. For example, an overdue review. Patients who I haven't seen in at least 28 days, I want to see them. Or patients who haven't come to the appointment in 28 days, I haven't reviewed it with a psychiatric provider, or the behavioral health manager hasn't talked to the psychiatrist about this case in 28 days, or we haven't gotten a PHQ-9 score, the depression scale, in 28 days. Let me go to active and prevention again. And what I actually should have done really is kind of talk to you about the different columns here, right? So we have, feels weird I'm doing this. We have the name over here, the age, date of birth, again, the patient status, the last review. And the last review, it refers to the behavioral health manager talking to a psychiatrist about the case to make sure that they've looked at the treatment plan, the diagnosis, and what medications they're using. Weeks, so the number of weeks of this particular treatment phase, right? So somebody starts integrated behavioral health, they're now in a treatment arc until the depression score drops by 50% or they go into remission. The last encounter. And then the type of encounter is, so the little person icon is a face-to-face encounter. The other one is virtual by phone. The PHQ-9 score. And again, the depression scores, if it matters, right? So low, low score is less depression, high score is higher. 20 and above, for example, is severe depression. And then the PHQ-9 score change. So what's nice is, if I'm trying to manage this patient population and try to understand, okay, who do I have in prevention and an active phase, I can sort it by PHQ-9 scores. The highest score goes to the top, and this gentleman, William Miller, he has severe depression. So I want to know, when's the last time I talked to him? When's the last time we reviewed this case? And when's the last time we got a score? So this is one where the behavioral health manager may want to make a phone call, have him come in the next few days, and check in with this person. A couple other things we can do. We can actually look at, for example, you see this little caret here? This person has 2 encounters as part of their treatment phase. This person over here, Peter Powell, has several other encounters and multiple different types of encounters, right? So I can actually go to a particular encounter. Let's look at September 12th. This is a phone encounter. And in this phone encounter, I can do a couple of things. I can look at the patient note, so the documentation that took place. So at some point, when somebody had this conversation, they went to the medical record, left a note, and now when I'm reviewing this case with my other teammates, we can actually look at this note, review what was said, what was discussed, and incorporate that data into our conversation. The other thing, remember what I said about the CPT codes. I need to record the amount of time spent in providing this care, right? And so here we can record actually the number of minutes that we spend talking about the case and the type of encounter this is. Another quick thing, let me go to, I'll click on Peter Powell here and show you some of the information that's presented. So what you're going to see here is that top graph, that's the trajectory of the PHQ-9 scores. This shows me what things are looking like. Is the patient getting better, getting worse? What does it look like? I can look at behavioral health diagnoses here, other conditions, medical diagnoses here. I have demographic data, Peter Powell here, social history down here in the lower left, medications, and the providers that are associated with Peter Powell. Going back to the patient list, a couple of other details. These little clocks here tell me when there's a sort of an alert. This patient, for example, hasn't been reviewed in the last 28 days, nor has this patient been seen in the last 28 days, and nor have we gotten a PHQ-9 score in the last 28 days. So again, I can sort by depression scores. I can sort by PHQ-9 change. Right, so I can look at the ones that who are deteriorating in presentation, and then try to target them that way. I want to highlight a couple other quick things. Looks like I only have 4 minutes left. Oh no, so a couple other things. Right here, so the admin page allows me to add or delete patients who are in integrated behavioral health. So we have a big patient population. Not everybody's engaged in integrated behavioral health. And the analytics part, this is the sexiest piece, and then I got to show the sexy thing. So this right here allows us to look at caseload by location, including the N. I can delete out some of the locations, so I can look at relative caseload by location, caseload by provider, with the N here when I hover. And then I can actually track the PHQ-9 scores, the average depression scores by provider on average, and by location on average. So again, I really want to make the argument here that this is population health in action. We're actually on the front lines trying to track these things, stratify risk, and try to get ahead of the problem before they end up in our emergency room. Thank you.